I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all. Thank you. Mr. Pratt, attorney certification of agenda, please.
Good afternoon, Board of Health members, Mr. President. The Attorney's Office has reviewed all of the items on your agenda today, and those have been reviewed and meet legal approval.
Okay, thank you. Are there any commissioner disclosure items for this agenda?
I have none, Mr. President.
No, sir.
None, sir.
Well, thank you. And I have none also. I have a wrong agenda in front of me here. But nonetheless, we can still move forward because I put the agenda together, so I know what it says. Before we start out, I'd like to make a few comments about today's meeting. First, I want to thank everybody for being here, and I want to note that we're going to focus today on COVID and the county's response. While there's a lot of good work being done to set up a county public health agency, that is really important. Today, we thought it was appropriate to provide an update on our COVID response and what trends we see in the data. First, I want to note that I'm extremely pleased with the great work being done by county staff and the school district staff. We have been working collaboratively with them on public health strategies, and last night they adopted a resolution that strikes the proper balance between ensuring students are in a safe environment, but also in an environment most conducive to learning. I want to commend county staff and school district staff for working together to best serve our community. Second, the Board of Health sent a letter to the school district providing intervention strategies that I am confident were useful to the district in crafting their resolution. I look forward to working with them in the future on a variety of public health issues, and I'm glad that we were able to work together on this one. We are one county, and I know that we can accomplish great things when working together. I also want to provide some context for today's meeting. We're going to hear from Fusion Cell, a public health consulting company with some of the best experts the nation has to offer, who provided a background paper on how the district could balance a safe public health environments with the best learning environments in our schools, and also advice for businesses and other organizations that operate within Douglas County. They're going to go through different public health interventions that can be used in lieu of universal masking. To be clear, there is a role for masking under certain circumstances, and Fusion Cell will discuss that. But universal masking need not be a policy intervention. My source for that claim, of course, is the state of Colorado, which had a mask mandate and lifted it and show no signs of reimposing one. Second, we're going to hear from CDPHE on Omicron and the impact of that new variant in Colorado. Finally, we're going to hear from Jogan, the contractor we have in place to manage our COVID response and who we are proud to say is a Douglas County company. There's a lot of encouraging data out there about, I think, COVID in Douglas County. Just about every trend appears to be in the right direction. The 3-day moving average incident rate is down. On November 22nd, it was 41.87. On November 29th, it was 33.67. And on December 6th, just earlier this week, it was 22.4. And that's good news. The December 6th rate is lower than Arapahoe, Adams, Denver, and Jefferson counties. In Douglas County, for children 0 to 17, we had 1 hospitalization over the last 3 weeks. And while 1 is not as good as 0, it is certainly better than 2, 3, 4, 5, 6, and so on. The 7-day incidence rate for children 0 to 17 has slightly increased as between November 22nd and November 28th, but it still appears to be trending in the right direction, downward from highs in mid-November, and we are lower than Adams and Arapahoe. At this point, it appears we are trending in the right direction, and that is good news, and we should all take confidence in that. Frankly, I want to thank the commissioners again, but publicly this time for their work. What we've been able to accomplish working with the school district, hiring an expert consulting firm, hiring a Douglas County company to work with us on COVID response is just a small part of their commitment they made to the community when they established a public health agency here in Douglas County, and I want to thank them for that. So with that, I would like to now move to the approval of the minutes, the consent agenda. Approval of the minutes for November 10th and November 12th, and also adoption of the 2022 Board of Health meeting schedule. So starting first, on the November 10th consent agenda, are there any revisions to the meeting minutes for that meeting?
No.
We have none. Second, on the November 12th, 2021 approval of meeting minutes, does anybody have any revisions to those meeting minutes?
No.
No.
Okay, I hear none. So let's move to adoption of the 2022 Board of Health meeting schedule, and I do want to talk about this for a moment. Is it possible to put that document up on the screen? Everybody should have it. It lays out basically when we're going to be meeting. There has been a request that I think we should discuss, that we start moving meetings a little bit later in order to accommodate the public more who can make the meetings. They feel if the meetings start after working hours. I did move the meeting to 4 o'clock from 3 o'clock on my own, but I wanted to discuss if folks felt that it was appropriate to move it even later and see if there are any recommendations on that. We can certainly have the freedom to meet as late as we would like. After working hours, we could do it at 5 o'clock, 6 o'clock, but I wanted to get the guidance of the board on that. Yes, Mr. Councilman.
Yeah, thank you. If we were going to move it later, I would prefer a Thursday than over a Wednesday. I have
Okay.
a conflict, a standing conflict on Wednesdays later in the evening.
Okay.
If that would be acceptable to the group. I don't know if that works for the other board members. But no restriction on Thursday for time for me.
Okay.
If
Yes, Doctor.
If it is a Thursday, and it is the second Thursday of the month, I have a standing conflict with that, with the FOC and the school board. So that would not work for me. A different Thursday, but for the next 3 months, then I might be tied into meeting via Zoom because our schedule for my work is set, and many times I will be working from 6 p.m. on to 2 a.m. on a shift. And so that is a problem for me if it runs too late.
Okay. Okay, I understand. So is that is general prohibition?
That's a general problem. If I know more than 3 months in advance, as I suspect you're putting the schedule in, then when I put in for the next 3 months starting in April, I can make allowance for it. But right now, making the allowances for January, February, and March will be a little difficult. I may be zooming in on some meetings.
Okay. Okay. And certainly we could, to accommodate that schedule, because I think it's important that you're here, and I think you probably want to be here.
I do if possible. If not, I can certainly be remote for the next 3 months, and then after that, accommodate a schedule.
Or we can do the next 3 months, starting, say, at 4 o'clock or
Yes.
something, and move the meetings to a later time. Do folks have an opinion on a later start time, a 5 o'clock start time, a 6 o'clock start time? If that's the case, if nobody feels strongly about it, why don't we, let me make this recommendation, and then people can shoot it down or not. Why don't we, in order to accommodate Dr. Fielding, let's say, because it's 3 meetings, because we'll be meeting monthly, why don't we start at 4 o'clock for January, February, and March, and then move it to 5 o'clock after that?
Yes,
Is 5 o'clock, is that?
No restriction.
no restriction.
Our Public Affairs Director has reminded me that commissioners have standing live town halls scheduled on Thursdays in this room. So we start the time checks at 5 p.m.
Okay,
So Thursdays to use this room are not going to be possible.
okay. So we need to, so there are, so Thursday, we may have to move the day of our meeting from Thursday. Did you had a prohibition on Wednesday? Is that the?
Yeah, yes, I have a standing conflict I typically have to leave by 5 is what we originally discussed when we set this time and day.
Okay,
Tuesdays, if we go the second or fourth Tuesday of the month, I will have less restrictions.
So commissioners have business and land use on Tuesdays, and so we can't commit that this room would be available before 5 o'clock.
okay. Okay, so what we could do, say Tuesdays, let's say 5:30?
I hope our land use are done by that, but that's not always the case.
That would be quick.
So
6 perhaps.
6, okay. So, because I thought that, did the land use get done at 5 o'clock, or is it start at 5 o'clock?
So they start at 2:30.
Oh, okay, okay.
But if we run a quick meeting and have one item, but if we have several meetings, I've been here many times until 7 or 8 o'clock at night.
Okay. Okay. So, it looks like Tuesday, Wednesdays, and Thursdays at a later time are difficult. That, of course, leaves Monday, and that is a problem.
The later time, the earlier, the 4 o'clock, or sorry, the 3 o'clock time slot works for me consistently, but
Okay.
the later time does not.
So why don't we let me recommend this, in lieu of having too much discussion on this, why don't we set them, I think Thursdays at 4 generally worked, right? Was that?
Thursdays I'm available, yeah.
Unless it's when we have a live town hall scheduled on Thursday and the time checks are at 5:30, or
Okay.
we start and then then the town hall starts at 6.
Okay, so one of two things, we would have to, let's keep them Thursdays at 4. If there is a conflict, then we'll just have to be done by 5:30. Basically, we'll have to schedule our meeting so that we can accommodate that. And if there is a problem and we need a longer meeting, maybe we start earlier. And then what I'd like to do is revisit this in January about trying to find a time where we can start a little bit later to see if we can accommodate it. But I think we can start working it out, and we can work with staff to see how, to start working with schedules with everybody.
Will we send out a survey monkey? Sam?
Yeah, that's what I'm thinking. That's exactly what I'm thinking we need to do.
Mr. President,
Yes,
could
sir.
I ask that we revive, where were we at on Wednesdays? What was our issue with Wednesdays?
So Wednesdays at 5, who had the conflict at Wednesdays at 5?
I do, yeah, I have a standing conflict on Monday, Wednesdays at 5, so Thursdays I'm available. And the earlier time slot works for me just fine as well. It's the public conflict, I think, is what you're trying to accommodate, right?
Well, that and Dr.
By
Fielding.
6 p.m.
But if you, see, Thursdays will work in the spring.
Right, it'll work in the spring for
So if we
me.
keep that locked down on that Thursday, and then we just need to accommodate a standing meeting that they may need access to the room for at 5:30.
Yeah, and that would work.
So let's keep Thursdays, let's keep 4 o'clock. Then what we'll do as we move into the spring, what we can do is move these meetings back, and they'll be able to provide notification.
Yeah, and if I have the, the dates of the schedule, then I'm just going to submit it after this meeting to our schedulers and make sure that's accommodated.
Okay.
Well, and Commissioner Thomas, I mean, I think we obviously don't do teletown halls every week during the month. I mean, I'm sure we could play around with deconflicting our commissioners' town halls and the meeting of this board.
I was just responding to what Wendy was texting me because she's got them booked in advance.
We'll just tell her to move those around.
All right, so the conclusion is keeping the Thursday meetings. We are starting them at 4, at least January, February, and March. And then when January, what we'll do is, once you have the opportunity to coordinate your schedule, we will probably move these meetings back to 5 or 6 o'clock in order to, and then in the meantime, we'll just have to do our best to continue to keep the public engaged. Everybody happy with that?
Pending their land use, yes.
Yes, yes. No, you can't say a thing. We have a resolution, we're done.
I just want to make sure I'm clear so that everyone else is. This will be the second Thursdays at 4 p.m. until modified.
Correct.
Okay.
And we anticipate modifying that in April. So that'll be the January meeting. We'll have an agenda item where Dr. Fielding then can come back and say,
Yes.
okay, 5 o'clock will work or 6 o'clock will work.
Right.
I think all we need now is a motion to approve the consent agenda items as modified.
Mr. Chair, I'm happy to make a motion to approve under the consent agenda items A, B, and C. C has the modified times as described by the attorney.
And second, all in favor?
Aye.
Aye.
Opposed? Great. We move through that pretty quickly. So what I would like to do now is call up, or have our first agenda item is a briefing on COVID-19 mitigation strategies by Fusion Cell. Is Fusion Cell on the line?
Yes, sir. This is Mike Linkshire, and I'm here. I'm waiting for Dan Foster, Dr. Foster, to join in on his link.
Okay. Well,
He's having technical difficulties right now.
if you want to go ahead and get started, I think you have a presentation, if we could put that up on the screen. And do you just want to go ahead and get started, Mr. Klingshire?
I can go without him.
Dan is actually on the line.
Oh,
Yeah.
perfect.
Hey, Mike, I'm up.
Awesome.
Great. Well, first, I just want to introduce briefly, these are the team that has been helping us develop COVID mitigation strategies. They were very helpful in authoring the letter that we sent over to the Board of Education and putting together basically what was a white paper on mitigation strategies, COVID mitigation strategies, and how to move forward on a mask optional environment in schools, but frankly in other public places as well. And that doesn't mean completely mask-free in all circumstances. There are circumstances where masks are an appropriate intervention, but they were critical in doing this. And Mr. Klingshire, I'm going to turn it over to you to introduce your team, which is an impressive group, and provide your briefing to the board.
Thank you very much. My name is Mike Klingshire. I'm the Director of Consulting over at Fusion Cell. And we're going to start off talking a little bit about Fusion Cell itself, how we got into the COVID mitigation strategies, who we've worked with to this point, and then a little bit about our team. Then we're going to jump into some of the prevention measures for reducing masks, and then also strategies to reduce the spread without the use of a defined quarantine.
Pardon me, Mike, this is Troy, your virtual host. Just wanted you to switch your screens. We are seeing presenters view.
Of course. Of course we are. All right. Let me stop sharing and reshare. Better?
Yes, thank you.
Perfect. All right, so Fusion Cell started off in 2019 as a staffing company with the sole purpose of helping transitioning military veterans bring that experience and expertise that they've honed over their years of service into the civilian marketplace. And that comes with a certain work ethic, and it's a very great mission. I love being a part of that team. Unfortunately, about a year after they started, a small little pandemic seemed to hit the world. And so companies decided not to hire a lot of folks as they shut things down in March of 2020. And so there was a pivot. And keeping with that veteran mentality, the question was asked, is there a certain skill set in the military that can help companies plan for how to reopen and stay open during the pandemic? And overwhelmingly, people said emergency management, public health, and the skill set of disease containment. So they put together a team. They asked for what skill sets are highly desired and who holds them. So they looked around, they found me as one of the first folks. And what we did is we built a team with some impressive certifications and backgrounds in disease prevention and also disease containment planning. So being able to respond to almost any scenario. And we've done this for decades. We've done it all across the globe. And so it's a skill set that we bring to the civilian marketplace that wasn't 100% there. And so backgrounds in biology, chemistry, pharmaceutical sciences, biostats, we have some clinicians on staff, lab officers, a whole range of folks. And we've worked with a lot of different federal agencies, so we know how to cut through some of the red tape. We're also very good at waiting in line when we call the CDC. So my background is pharmacology as my bachelor's, and then epidemiology as my master's in public health. I joined the Air Force. I spent 10 years active duty as a public health officer, and that is the equivalent of running a health department on an installation. So everything from occupational health, disease tracking, communicable disease interventions, and just generally maintaining a healthy state of the population that's on base. I've done my skill set in 3 different states. I've done it at a command level, overseeing Middle East operations, and I've also done it while deployed, mainly to the Middle East and Africa.
So, stepping in here, I'm Dr. Dan Foster. I'm a 15-year Navy veteran physician with a background in occupational environmental medicine, preventive medicine, and aerospace medicine. Not to belabor my experiences, but most recently, I spent 2020 out in the Pacific Rim on an aircraft carrier as a senior medical officer running the medical department in response to and mitigating COVID's effects so that we could continue to stay deployed. Currently, I am in charge of COVAX delivery for not just Navy and Marine Corps personnel, but I'm also leading a medical team that focuses on primary care and ensuring that we have deploying personnel ready to go overseas at all times. This encompasses all sorts of vaccinations across the spectrum.
Thank you. Also on the team, but not presenting today, we have Jimmy Adelani. So much like me, public health officer, background in epidemiology, just like me, multiple deployments. And then she was the first person that I brought on to the team as we started doing COVID consulting. So she's been with us since the beginning. She helped hone our methodology, but she has all the same health department experience running and delivering on that side of the house. Tomas Fiedemann is working on his doctorate in public health right now in epidemiology. He's got a background in industrial hygiene. He's a public health officer in the Air Force. He's got a Navy background, and he's been on the team as well for quite a bit of time. Once again, the same health department experience. And then we have Tammy Shaw. So she is in charge of all of our laboratory stuff. So as questions come up about testing and how to interpret results and what's the proper sequence of testing, it falls on Tammy, and she's been all over the globe, and she's been delivering lab services and even developing lab tests to battle some of the most high-profile diseases that are out there.
Nobody from the Army? I mean,
yeah, nobody from the Army quite yet, but we're working on it. We're growing.
the public office.
We have been pretty busy, and so we have had a lot of folks reach out for help, and we've done everything from helping schools plan before CDC guidance was published, to helping businesses, offices reopen, working with hotel and lodging industries, and even into the airport sector. So helping maintain those continuity of operation plans and making sure that they're capable of responding to anything that's out there. And in the middle of all that, we've even planned or helped plan some safe events for in-person conferences. So our methodology focuses a lot on 6 non-pharmaceutical interventions, NPIs. These are working with the HVAC system, because the HVAC is one of the most critical components to controlling disease transmission. As we learn more about COVID over time, we started off thinking it was droplet and contact transmission, and then in October of 2020, the CDC acknowledged that it's airborne. And so as we learn more, we realize there's some strategies that we need to adjust and implement to make sure that we can contain the risk as much as possible within certain environments. Disinfection, making sure that things are appropriately used and that those kill times are happening. Exclusion. This one's one that I think has been hammered home over the last 2 years, but the idea of staying home when you're ill. So even mild symptoms, you should probably stay home and go get tested and see what you need to do to take care of yourself and take care of your health. And then once we have these healthy buildings and we have our healthy populations coming in, it's about distance, the use of masks, and hand hygiene. And when I say masks, as I will acknowledge that masks absolutely have a purpose, but sometimes the overuse of masks, although not inappropriate, is not as effective as some of the other strategies. So augmenting those big 6, things we can also do at a population and individual level to reduce risk. Vaccination remains highly effective. So the studies that are coming out talking about vaccine effectiveness specific to the Delta variant out of New York State, it's a pretty big study. Roughly 78% protection from infection, and still in the 90s for protection from hospitalization. So vaccines remain a very good strategy to put in place for personal protection and also to reduce the at-risk population within an organization. Testing. Testing has a very great use, and that is to identify symptoms, to tell you if you're COVID positive, and just to give you a check to make sure that you're still healthy and you can be in the population, because what we want to do is maintain some of those mask optional areas, but it relies on knowing that we are healthy individuals. So operating without a mask mandate. And so first and foremost, always we need to acknowledge that while there's community transmission of COVID, we cannot eliminate risk completely. It's just a nature of the disease and transmission. And we know that there are 6 pieces to our methodology that work together. Each of them acts as a different layer, almost. And so the idea is that each layer is imperfect in itself and requires extra mitigations. So for instance, HVAC systems sometimes have trouble dealing with those very close interactions because air just doesn't move fast enough to take care of droplet precautions. So when you're very close to somebody and talking and you sneeze, an HVAC system is not going to stop you from sliming somebody else. But we can augment that. And so I think that that's the big consideration here, is that we're not talking about a free for all and no masks ever, but it's more of a tailored situational implementation of masks to make sure that they're used in the appropriate situations and that we can take them off and get back to normal work in other situations. And so as we learn more, like I mentioned, HVAC is becoming more critical. So being able to bring in fresh air, being able to mechanically filter, being able to disinfect the air with UV lights and other items. Really, it's a holistic approach, this big multi-layered piece of the puzzle that helps us get to risk reduction and reduce that risk to an acceptable level so that in general, we don't need to wear a mask, but in very specific circumstances, we may need to. And as we layer in vaccination and fewer susceptible people, as we layer in testing, we further reduce that risk. And so those are also tools to consider as an organization is lifting mask requirements. And I think that last night proved a point that there are a lot of studies out there of some of the negative effects that masks have. And yesterday's focus at the Board of Education was focused mostly on students, but a couple of studies that we linked in here are people of all ages and how mental health has been affected over the course of wearing a mask in certain circumstances.
So, hey, thank you, Mike. Mike brings out quite a few very important factors as we look at overall approach to supporting an approach where we can reduce or do away with quarantine outside of an outbreak. Now, when we address this, we have to look in terms of vaccination status. One of the in individuals that are vaccinated, the CDC has already given us clear guidance that those vaccinated close contacts of a known COVID positive, as long as they're symptom-free, adhere to basic guidelines, masking, social distancing, and hygiene. One of the things that that would be emphasized would be a 14-day masking, or until a negative test is received when in public or around other people. Another item that I'll cover a little more in detail on the next slide is active symptom monitoring for the full 14 days. And then as a health status check, a PCR or a COVID test at approximately day 5 to 7. Our next level is those that are unvaccinated. Now, this is where we're going to go into a little more detail. Based on the CDC guidelines as far as close contacts, those unvaccinated individuals that are close contacts to a known positive need to adhere to, as long as they are asymptomatic, masking, social distancing, and hand hygiene as before. But when it comes to the 10 to 14 day masking period, we don't have an option at this point to really test out. So as a layer of protection, that mask is there. The next layer is active symptom monitoring. And I'll anchor a little bit on this because in a collegiate athlete study that looked at a little over 1,800 athletes across 17 different states, who were quarantined for exposure to a known COVID positive. Symptoms reported, as in their symptoms that they reported, were predictive of their eventual outcome as far as testing. So what that means, and the numbers stipulate, that 90% of those who reported no symptoms never tested positive during their 14-day quarantine, as opposed to 83% of those who reported symptoms eventually testing positive. In a study looking at exposed travelers, a shortened quarantine with a combined with active symptom monitoring was actually demonstrated to be just as effective as a 14-day period. This was also reinforced in modeling studies looking at close contacts within using again the close physical distancing, masking, etc. Now, the next thing we go to is, again, serial testing. And as mentioned before, the testing is a health status. So a verification that they are still healthy. As long as the members are, or individuals are not experiencing symptoms, recommendation for a day 3, 5, and 7 testing, as those are the most affected, reinforced by studies that demonstrate that the longer an individual is in quarantine, entering quarantine with a negative test, and tested serially throughout this quarantine, their risk of testing positive is approximately 27%, which drops to less than 5% by day 10. The same study demonstrated a mean rate of days to positivity of 3.8, with approximately 86% of those that tested positive testing positive at or before day 7. This reinforces the consideration for the serial testing in conjunction with active serial active symptom and also the mask. Again, thank you very much for your time and consideration.
Thanks, Dan. So just to summarize a little bit about what we talked about. First and foremost, we had a team of 6, 5 are present for this meeting, working on this slide deck, working on the considerations, working on that white paper that we drafted up the report for the Board of Health. And so we have done public health. We've done it all over the globe, and we've done it in a bunch of different environments. Over the last almost 2 years of doing COVID consulting, we've worked with a multitude of organizations, and we've really honed in on what our non-pharmaceutical and pharmaceutical interventions are to help tailor an environment to the specific risk reduction and risk tolerance of organizational leadership. There are absolutely safe ways to live and work and study in a mask optional environment. But that doesn't mean a no mask ever environment. So we acknowledge that masks alone are not the end all, but they are a specific tool that can be employed at certain times of the day to reduce risk even further. I love saying that an exposure does not need to equal disease transmission. A lot of times we see people that will go the full length of quarantine and never develop signs and symptoms and never test positive. And so they spent, sometimes 7 to 14 days reducing all of their orbital structures, not going out to get groceries, not going to the bank, not doing student drop-off, not going to work. And so the idea of how do we apply known risk reduction principles that quarantine delivers without requiring quarantine. And so that idea of keeping a mask on, self-monitoring, because we know that if you are asymptomatic, you're less likely to test positive. And we know that if you're symptomatic, you're more likely to test positive. So keeping an eye on your own health is a great indicator on when to get tested. And then testing itself. The longer you go into quarantine without symptoms developing, the less likely it is that you're going to develop signs and symptoms or test positive for COVID. As Dan said, if you make it to day 7, only about 13% of people will test positive after that if you have a negative test on day 7. And so testing can be used as a strategy to get to those risk reduction principles of a quarantine without taking away your ability to have a normal or somewhat normal life. You may have to wear a mask and you may have to self-monitor for 14 days, but in the broad sense of it, it gets you back to a sense of normalcy. So it lessens that economic impact. That is the end of my slide deck. We have references of everything that was cited in the presentation, and we will send this out to the Board of Health so that they have this as reference material to go with their minutes.
Thank you. Thank you for that presentation. It was very helpful, and I'm afraid the mic caught me ribbing Commissioner Teal about there are nobody from the Army on your team, and Commissioner Teal is a veteran of the United States Army, so I guess they all get elected to be county commissioners. I would like to open up to questioning. Dr. Fielding.
Yes, there's just one thing that I would like to clarify in terms of masking. And I've brought 3 examples here, so I would like to know what you're really recommending in your mask mitigation strategy. First, there's this mask. It's Christmas cloth. It's very pretty, but it's probably terribly ineffective. But this is a mask. Second, this is a medical mask. It's a standard use in a hospital, not for viruses, and should be changed every 2 to 3 hours, but they tend to end up looking like this. And finally, here's your duckbill, which really is your viral protection. But you can't wear this if you have a beard. So when you're talking about masking, what exactly, what type of mask and how the use of them would apply would be very interesting for me to hear.
Dr. Foster, Mr. Klingshirn.
Masking, because lots of things are called masks. And so when you brought up the example of the cloth mask, so a single-ply cloth mask is relatively ineffective. When we start talking about cloth face coverings and the most effective pieces, we're really talking about 2-ply or 3-ply fabrics. Cotton on the inside. You can have synthetic fibers on the outside. You can also have synthetic or cotton in the middle, depending on your preference. And those, coupled with some of the risk reduction methods, can absolutely decrease the idea of transmission and slightly decrease or slightly increase your protection. And so I do want to say that the best mask to wear is the one that fits your face and fits properly and forms a seal over your nose, under your chin, and to the sides of your cheek. If it's a loose mask, it does really no significant benefit. And so the idea of the mask is that it filters things that are coming out of your lungs and also things that are coming back into your lungs. Surgical style masks, they do have a better fit. They do have better effectiveness than a cloth mask. So as you tier these, cloth masks, when there are 2 or 3 layers, are probably your lowest level of masking, as long as they fit appropriately. Surgical styles are right in the middle. Usually they have a static charge that helps increase their filtration. And so you are absolutely correct that you should only use them for about a day and then throw them away. A day being an 8-hour day. And so reusing a surgical mask means that you're just basically putting a piece of paper over your face. It does very little after about a day. And then you talked about the duckbills, so the N95s or KN95s, and those are not typically classified as masks. They're classified as respirators and personal protective equipment. And so those require, for proper use, an annual fit test on the make and model and size of the one that you're using. So if you constantly switch based on availability, to have a good proper fit, you would need to be fit tested on those. And there's a process where they spray something in the air, you breathe for a little bit, and if you taste it, then it's not the right mask. But most people don't go through that rigor. And so you're correct that the proper fit of a mask is very critical, but also critical is the use and the type and the material of the mask.
Yes, and so what actually, when you say masking, are you recommending that we do as masking for the general public?
Great question. So the practical implication of a cloth mask would be a 2 or 3 layered approach, or a surgical style mask. You can have waivers. If it's an employee, you can have a humanitarian use piece in your HR policy so that you're not subject to providing a respirator fit test if you're going to allow people to wear N95s. It's just an admin piece to allow it as a side effect of the pandemic. And so I would recommend whichever one is available and fits the face. So if that's a 2-ply cloth face covering, then that works. If it's a surgical style mask, then that works.
Okay, because that's my last comment on it. I have just the last one, and then I will be kind. But if you have facial hair, none of these work. So are we going to mandate face shields? I mean, this becomes a big issue for the general public.
That is a very good question about facial hair. So facial hair definitely decreases the effectiveness of a mask because it does not allow that tight seal around your cheeks. And so the idea of do we require no facial hair? I don't think that we need to go to that. Do we require face shields? Face shields are more of a person protective piece. So they stop you from being exposed to COVID more so than they stop you from transmitting COVID. So it doesn't help with source spread. So face shields in conjunction with stuff, in conjunction with the 2-ply or higher mask or surgical style masks can be effective at prevention. Remember that just because you have facial hair, depending on the level, doesn't mean that the mask doesn't fit. It just doesn't fit as well. And so there's decreased efficacy, but it's not zero efficacy. There's still a spectrum of protection.
Councilman.
Yes. So I apologize. I grabbed the pen a little bit late. So if I don't follow your numbers, please correct me. So you said that you tracked roughly 1,800 students over 7 to 8 states. And if I'm looking at the numbers, you said that 90% of the folks that were exposed to COVID, to a COVID positive patient, and then 96% of those athletes were negative. So is that if I'm following the math right, is that a 4% positivity rate based on 1,800 exposures?
Okay, hey, this is Dr. Foster. So the number was 90% that had reported no symptoms throughout the entire 14-day quarantine period. Of those, 10% eventually, actually the real tried and true numbers are actually 9.5%, but rounded down 10%, eventually tested positive. Of those that reported symptoms at the outset or throughout at any time during that quarantine period, 16 to 17% eventually tested negative, 83% tested positive. Does that answer your question?
Yeah, it does. So in what I heard from your presentation is that it sounds like your recommendation at first symptoms, certainly wear a mask to protect those around you with the sense of quarantine at exposure. So does that sound accurate? Did I hear that correct?
That is correct. So yeah, the act of putting the mask on is one level, then actively monitoring symptoms and, being expecting, and as a doctor in the clinic, I usually expect that my patients are going to tell me the truth. I would hope they would. And so in active symptom monitoring, we trust that those individuals that are reporting are going to tell us the truth.
So it sounds like common sense. If you don't feel well, you should perhaps wear a mask to protect those around you and not expect that everyone around you should wear a mask. Does that seem accurate?
Absolutely. Absolutely.
Okay. Thank you.
Thank you. Commissioner Thomas, Commissioner Teal.
Thank you, Mr. President. Mr. Klingshirm, Dr. Foster, Commissioner Teal here. My question would be, actually, I hope to touch on and get your advice on questions around natural immunity and how that could be factored into a public health strategy. And at this stage, based on numbers reported from the Colorado Department of Public Health and Environment, approximately 13% of Douglas County has been exposed to COVID-19. There were positive test cases being tracked by the state. At the same token, actually, a second question pertaining to how that can be integrated in terms of our thoughts around herd immunity based on our vaccination rates. So I noticed that you didn't reference any sort of natural immunity. You focused on vaccination. I wonder if you could take a few moments to give us advice on natural immunity and how that can factor in a public health strategy, as well as how that could factor into advice to our residents from a public health point of view.
Copy. So you raise an excellent point. To date, and as we're going throughout this, the biggest problem that I find with natural immunity is that our technology has not focused on, say, let's jump over to, say, like measles, mumps, and rubella. We vaccinate against that, right? Primarily because of the massive health impact in the population, particularly among children. What we know and what we have developed are titers that we can actually draw to say, yes, you've developed immunity secondary to the introduction of the vaccine. The biggest thing that we have to rely on with regard to COVID natural immunity is that we don't have much that establishes anything beyond a 90-day period. And unfortunately, the testing that we do have that looks at antigen testing is less less sensitive, so requires a higher amount of IgG, which is the immunoglobulin that our bodies produce. It requires a higher amount of that to be detectable. We don't have a test specifically at this time that I'm tracking that can verify a natural immunity. Not saying that it does not exist, but we just don't have enough evidence. Does that answer your question?
It does.
If I can just jump in for a sec. So we do know that there's at least protection up to the 90-day mark after an infection. And that's what we've seen and what the data is supporting right now. As we go through this pandemic, much like with the HVAC systems, we learn more about it every single day. And so now the idea is tracking those that have only had a COVID infection, seeing how their immunity reacts over time, and then also factoring in the fact that these viruses tend to mutate frequently. And so natural immunity doesn't mean forever immunity, but it does give protection. And so we do know that if it's 90 days, if you're in that window, you're very unlikely to develop COVID as a reinfection. And so I would, and Dan, correct me if I'm wrong, I would probably put those with a documented case. And when I say documented, it's not, oh, I got sick last week, I had COVID, I'm immune for 90 days. I would say if you went and you got seen, or if you had a positive test as that documentation piece, I would put them more in the vaccinated category where they don't have to, where they can use your masking, and they can use active symptom surveillance, but they don't need to do that serial testing. A test on day 7 will likely catch the vast majority of reinfections in that population. And if they're negative there, then they can pull the masks off.
Okay. Please continue.
Go ahead. What I was going to just point out is that, again, natural immunity it's there. But again, secondary to the mutation of this virus. And that's why if you look at this in cross-reference what we follow every year with flu, flu changes every year. That's the reason why the WHO has to predict what virus is likely going to be the most common, and then tailor the vaccine that they give based on what the predictive model will be for the following year. It does, and as we know, the vaccines vary in efficacy. As I'm seeing, though, right now, with the mutations that we have so far, the vaccines for COVAX are actually fairly effective, which I would, if you want to draw a corollary there, I would say someone who has been infected with COVID would equally be, if their immunity would be equally effective. And I definitely would recommend against testing within 90 days after they've been infected. Any other questions?
I think that answers my questions for now. Thank you.
Commissioner Teal. Excuse me, Commissioner Thomas. I apologize.
Thank you, Mr. President. So going along with the questions that Commissioner Teal started asking you about natural immunity, so what role does it play when individuals get ongoing blood tests? I've heard people can go to King Soopers and get tests that show their antibody levels even after 90 days. So what consideration can be made for that availability of those blood tests?
Okay, so I'll take this one. This is Cammie. So the thing to remember with the antibody tests is that while they may demonstrate that there are antibodies present, at this time we don't know enough about the efficacy of those antibodies in terms of immunity. So we have so far kind of focused on that 90-day window because there's a strong correlation between antibody presence at high enough levels to confer immunity. But past that point, it's kind of hit or miss whether there's enough immunity to prevent either transmission or reinfection or a subsequent infection that is in a strong way correlated to the level of antibodies that are present within the body, if that makes sense.
Thank you.
Councilman.
Yeah, so is it fair to say that, so the PCR testing, is essentially testing the presence of the acid within the coronavirus once it's broken down and then multiplied. And then the antigen test is testing the proteins on the outer shell of the virus, and you need a given viral load to be able to detect it, right? So my question is, if we're just going to look retrospectively at whether you have COVID or not, what is the level of antibodies in the baseline that seems acceptable to detect and to measure whether you are outside that 90 days? So the point I'm getting at is if we're just going to look retrospectively at this forever, at what point do we develop a baseline that says that you are now protected immunity by a blood test? Is that forthcoming? Is that in the works? Is there anything that's being looked at for future state in this space?
Absolutely. So one of the bigger challenges when it comes to the antibody testing that's out there are different manufacturers. So let's just, for example, a 5 on a particular method may be the equivalent to a 10 on another. So there's no set groundwork for this titer tells us you still have immunity from COVID just based off of your antibody profile. There's so many manufacturers out there with an EUA for studying this or for testing this, that we're at the point of collecting a bunch of data is really what it comes down to. And that's really the entirety of the pandemic for us, right? Is we learn as the science evolves. So for antibody testings, now that we have longer periods of time where there are several studies through the NIH, the military, the different services have their own research studies going on right now over the same topic, because it is important to understand at what point are those boosters needed, because that plays the piece there too, is looking at what point has our antibody levels dropped so low that we need to do something to further boost our immunity. So it's in the works, but I could not give you any promises on how far in the future that might be. But good question, you know your science.
Thank you. And the follow-up question to that is given the viral load in children is typically extremely low, does your organization, are they seeing or recommending that children of given age be vaccinated? And if so, what is the data that you're pointing to? And if you could send that to me, that would be great if you have it. Thank you.
Commissioner Teal.
Guys, you really, this information has really got me thinking about things. But to close the loop on a thought that I'm having, though, is there a difference in efficacy between the reliability of a positive antigen test, a positive test on a positive result on a quick antigen test versus the positive result from a more in-depth PCR test?
Yes, absolutely. However, there is a key difference between the two. So a molecular-based test, so the PCR method is the most commonly referred one, is testing for presence of the virus or RNA of the virus. That doesn't necessarily mean that that person is infectious at that point. And that tends to be one of the challenges, is that you can remain positive for a long period of time. That's also why they recommend not doing a PCR test for the 90 days following someone who has a known positive. Your antigen-based tests, while are less sensitive, are more likely to give you an accurate picture of an acute infection right then and there. So they both have their pros and cons, but in the terms of looking at who is infectious right at that moment, an antigen-based method is more likely to give you confidence that there is an active infection that you can transmit to another.
Cool. So to ask a slightly sharper question, two people, one with a positive PCR test, one with a positive antigen test, high, near perfect certainty that yes, they are infected with COVID.
Yes, absolutely. So they're very, very rare. I can't even think of an example in any of the scientific literature of someone who is positive on both an antigen and a PCR without an active infection.
Okay, thank you.
And just to follow up, do you have a recommendation on the vaccination for adolescents and children?
Hey, this is Mike Linkshern. So we usually, when we talk to students, when we talk to families, when we talk to everybody that has a kid, we recognize that vaccination is a highly personal decision, and the risk of COVID needs to be weighed with the risk of vaccination in some of those outcomes. So in general, we do not recommend schools do vaccine mandates. We recommend that they educate, that they provide as much information and access as possible so that families can make the right decisions for them.
Okay, thank you. And if you have any data on that, I'd love to have it if you could send it on. Thank you. That's all, Mr. President.
Thank you.
I have
Dr. Fielding.
one last question, and again, it's just a minor clarification. Are you advocating a broad screening program or only testing people that you know have contacted, been in close contact with a case? Because depending on how broad the screening is, should we, at the beginning of, say, a session, screen everybody walking into the room, since it looks like many cases may be asymptomatic and you may never catch them. From what I'm understanding, the asymptomatic people probably are at a very low risk for transmission.
That's an excellent question. So the recommendation would be for screening tests, correct?
Yes.
Is that what?
Yeah.
Okay,
So who do you recommend that we would actually test?
Would be those that are actually close contacts to a known positive.
Mm-hmm. Okay.
So what the broader sense would be what would be referred to as sentinel testing. That is not what the intent is.
All right, because I know that many hospital systems in town are, still checking temperatures, checking every day. Do you have symptoms? And, maybe if people have been asymptomatic for months and they've been vaccinated, this is not the best use of resources.
Well, I think, Dr. Fielding, I think you bring up a very good point of defining what an exposure is.
Yes.
And defining what an exposure is, if it's at a gymnasium with a gym class with lots of space and a positive test, is different than close square footage, right? So I think defining what that exposure is perhaps is not for today's discussion with this group, but I think that's important to understand.
Well, and Councilman Bracken, you bring up a good point, and I was going to wrap up unless there are. So a few things strike me from this conversation, which, by the way, was a great one. And like the board, thank you for your great questions, and thank you, Fusion Cell, for thoughtful responses. A couple of things. I do think it would serve us well to dive deeper into, not right now, but moving forward, the natural immunity questions that were brought up by Commissioner Thomas and Commissioner Teal, and determine how that fits into our intervention strategies and address it up front. I think we need to address that, and I think parents will want to have greater understanding of that, and the public generally will want to have greater understanding of that. So I would flag that for you all, Fusion Cell, as something that I would like to follow up on and get some additional guidance from you. Second, a lot of the questions that were brought up here are going to be brought up generally, and I think specifically by our friends over at the school district. And what I would like to suggest and direct moving forward is that you coordinate with the school district, because they're going to have, like, particularly on the question of what is contact. I think they're going to have some of those similar questions, and I think they would benefit from some of the guidance that you would provide them. If you would, and we can arrange this, if you would make time to visit with the school district and brief the school district, I think that would be useful. One, two, also Jogan, our contractor who's doing COVID response, I think we need to get you and the school district and Jogan all together so that we can have a coordinated response and coordinated message going out to the public. So if we would, Mr. Pratt's writing this down, thank you. We will follow up with you to do that coordination, and we'll set up time, probably separately, or we'll set up time to work with Jogan and work with the school district so that everybody is hearing the same message moving forward in Douglas County. I think that there's a great need for that. What I would like to do, if there are no other questions, is move to public comment on this. And I would first take public comment in the room, and then we will move to the phones. So please. And just, you know the drill, Carl. Name and town you live in would be great.
Carl Dierenbach, Centennial, Colorado. Fusion starts with the premise that COVID presents an exceptional risk to students, and therefore mitigation is justified. I don't agree with that premise. According to CDPHE, for ages 0 to 19, the Colorado COVID hospitalization rate with COVID is about 28 per 100,000 per year. 710 kids total through the pandemic out of like 1.5 million. According to the CDC, for ages 0 to 17, the hospitalization rate during the 2018-2019 flu season was about 53 per 100,000. 28 for COVID, 53 for the flu. That means flu is 1.9 times more likely than COVID to put a kid in the hospital. Thank God, COVID is not an exceptional threat to children. Furthermore, COVID is not an exceptional threat to children with asthma and other pre-existing conditions, but with asthma. Here we have to distinguish between two different values. First, yes, asthma represents an elevated threat with respect to COVID as compared to children who do not have asthma. But second, COVID does not present an exceptional threat to kids with COVID as compared to seasonal influenza for kids that have asthma. In other words, although asthma sufferers face an elevated risk from COVID, it is comparable to the elevated risk they face from seasonal influenza, and therefore it does not present an overall exceptional risk compared to what asthma sufferers face year over year. I bring this up because of the Fusion study where they say, in a large 16-month retrospective cohort study among children aged 5 to 17, she et al. Demonstrated that hospital admission with higher acuity care was higher among children with a prior diagnosis of asthma, which also increased based on how well it was controlled, meaning they're saying that people with asthma are particularly susceptible to COVID. True, but they leave out that that's a common thing that happens every flu season. In fact, the paper Fusion cited in support of that statement from Scotland notes children with asthma were found to be at an increased risk of COVID-19 hospitalization admission, adjusted hazard ratio of 1.49 compared to those without asthma. Again, COVID, people with asthma are susceptible to COVID. But that Fusion cited paper also cites to another paper, which is a study from mostly UK researchers about influenza and pre-existing conditions from 2018 that states asthma represented a risk factor for hospitalization during influenza season in the general population with an odds ratio of 2.6 in 2 Canadian studies and a relative risk ratio of 4.47 in Israel. The same applied to children where asthma conferred a 4-fold risk of hospitalization in the US, Germany, and Argentina with a 21-fold risk observed in South Korea. My point in all these numbers is to drive home the point that COVID does not represent an exceptional risk to children. Even kids with pre-existing condition are seeing elevated risk levels from COVID that are on the same order of magnitude as the elevated risk levels they see during a bad flu season. Given such statistics, and the fact that any staff in Douglas County schools has either been vaccinated or fully accepts the risks of remaining unvaccinated, there is simply no COVID-specific reason to enact any of the Fusion recommendations. You might do it as a general trying to be healthier, but they're not COVID-specific. And if I had more time, I'd get into the ineffectiveness of surface cleaning, social distancing, and mask wearing in general. But the bottom line is, just be brave, just go back to normal. Thank you.
Thank you. Any other Yes.
Hi, Miles Cortez, Centennial. Carl and I didn't compare notes, but we have a similar take here. Last night at the school board meeting, there was a lot of talk about masks and mitigation and even the Fusion Cell report. But today I want to take a step back and look at COVID from a 50,000-foot level. And I submit to you, like Carl just said, COVID is not dangerous to kids. Therefore, it doesn't require any mitigation at all above and beyond what we've already done for seasonal illnesses like the flu or RSV. This is what the data tells us. There have been approximately 350 deaths per year from pediatric deaths from COVID per year for pediatrics, if you believe that all those deaths are properly attributed to being from COVID and not just with COVID. I don't accept that those are properly classified, but I don't need them to be to prove my point. So let's talk data and science. COVID isn't alive, but the numbers are. This is a chart from the New England Journal of Medicine that shows pediatric deaths from all causes in 2016. Suicides are 6.7 times more likely to occur than COVID deaths. Drownings are 3 times more deadly. Unintentional drug overdose, 2x. The list goes on and on. But the COVID would barely make the top 10, even accepting the classifications as they are. And I'd ask how many would have fallen under other categories up here like cancer or respiratory disease. Indeed, the one pediatric death in Douglas County over the last 2 years was sadly a child with cancer, as far as I know. If the primary role of a public health entity is to protect the health of the population, it would seem to me that there are a variety of other areas that should be the focus of this Board of Health. Maybe seatbelts on buses, for instance. But let's go back to the flu, the major seasonal illness. There were 1,161 flu deaths, according to the CDC, in the 2012 flu season. That's 3x what we have this year. Yet that year, there were no specific accommodations. Why then do we need an additional mitigation or ADA accommodations at all? Were the kids in 2012 and 13, when flu deaths were so high, were they asking for all the kids to be masked? Were they claiming to be denied access to their education through the ADA? There's simply not evidence to suggest that COVID is dangerous for kids or that it requires mitigation beyond common sense. With all due respect to Dan and Mike, and thank you for your service to this country, when you're a hammer, everything looks like a nail. So when you're a COVID mitigation company, everything looks like it needs to be mitigated. The 6 things that they put up there, 5 of them we've always done. If you're sick, stay home. Wash your hands. Cover your mouth when you sneeze. The only new one up there is masking. The notion that of unproven vaccines for otherwise healthy kids is absurd to me. The data and the science are clear. This week we heard that the Omicron variant is hyper-transmissible because it shares genetic code with the common cold. So now we know that genetically what the data has already told us, statistically what we know from the data, and anecdotally what parents know, that this is a lot like a common seasonal illness and should be mitigated and accommodated as such. Thank you for your time.
Thank you. Do we have any comments online?
Thank you, Mr. President. I do have a couple. First up is Aiko Browning. Forgive me if I did not pronounce your name correctly. You are unmuted. Go ahead.
Hello, Board of Health. My name is Aiko Browning. I am a parent of 2 children in Douglas County Schools, and I'm a practicing physician. I support layered COVID mitigation measures, and I was very pleased to read the fusion cell report, including their big 6 measures. Having an environment with the lowest possible level of COVID transmission benefits student, teacher, and staff safety. Having the lowest possible level of COVID transmission promotes continued in-person learning, which in public education, these are goals we should all support. Now, I have several questions for the fusion cell experts. First is, why are you recommending HVAC over masks rather than HVAC in addition to masks for continued increased mitigation in these environments? My second question is, are there comparative effectiveness analyses of HVAC versus mask wearing, such as surgical masks or N95 masks? And are there cost-effective analyses? Because it seems like we already have cost-effective air filtration measures in the form of universal masking, although that's now gone as of last night. I would also like to know, in your expertise, what are the usual costs for high-quality HVAC upgrades for buildings? Do you believe that the Board of Education resolution passed last night is consistent with the fusion cell recommendations? And how do you reconcile your layered Big 6 recommendations with the recommendations by the CDC and the American Academy of Pediatrics for universal K-12 mask wearing protocol? And that is my statement. Thank you for your time.
Thank you. Other callers online?
Thank you, Mr. President. I do have one more caller. Robert Marshall, you are unmuted. Go ahead.
Thank you. Oh, and if I would just remind if folks would give their name and the town they live in, I would appreciate it.
Okay, I'm Robert Marshall in Highlands Ranch, Colorado. Can you all hear me?
Yes, we can.
All right, so the fusion cell report, I was very pleased when I read it because, to be quite honest, I thought it was going to be just a whitewash for the board and the school board and the health board to just get rid of masks. The fusion cell report's at least a legitimate effort to look at ways, if you are going to get rid of universal masking, that there's other things in place. The concern, though, is you sent it all over to the school board, and they did not act on any of those before getting rid of the universal masking requirement, which made no sense. And as the Board of Health, I would think you would have some kind of responsibility or ability to tell the school that district, if you were doing your proper job, to tell them this is your opportunity to look at getting rid of universal masking, but you're going to have to do something in order to protect these people. Find the reasonable accommodations before you get rid of the reasonable accommodation the court already said you needed to have in place. That just didn't really make any sense. The second item, too, is I asked an Acora request for any copies of the scope of work or the contract with Fusion. I was told there is none. I'm like, did Fusion do this gratis for the county? I mean, in the federal government, it would be illegal to do that. And I kind of suspect that there's no way they did it gratis. So why are the contracts and scope of work not available? I was told that they might be under AC privilege, but what kind of possible attorney advice could the county be giving Fusion if they're giving a public report? That's real disturbing if that's what's going on. The final little point is, the Fusion Cell is looking at reducing the infection rate. That's right in the bailiwick and the wheelhouse of this Board of Health. The Colorado Revised Statute 25 TAC 1506 puts out 15 duties for this board. None of them are to go for mental health just in general, but 4 of them go directly to investigate and control the causes of epidemic or communicable diseases and conditions affecting public health, or to establish, maintain, and enforce isolation and quarantine, and in pursuance thereof, and for the purpose only, to exercise physical control over property and over the persons of the people within the jurisdiction. Your powers and your duties are to take care of infectious diseases, and it's like you're trying to avoid doing your very duties. And then because of the prior speaker, I do wish to emphasize to the board that you're the county's Board of Health. Just because everyone says, oh, it doesn't affect children as much, schools are the primary transmission point for all infectious diseases. All reasonable boards of health understand that. It's the first transmission point because the kids come in, the kids come out, they come in, get in close contact, spread it among themselves, and take it back out. So you're turning them all into little vectors. You do need to control what's going on in the schools for the general public. So thank you.
Thank you. Are there any other callers? Or callers
I have no other
online commenters?
No other online comments, sir.
Okay, thank you. I guess let me turn to Fusion Cell for a moment because there were a couple of questions with respect to sort of HVAC versus mass versus having both. And also a question with respect to comparative effectiveness of each and sort of cost-benefit analysis. Dr. Foster or Mr. Klingshirn, do you have any comment on those items?
This is Mike Klingshirn. These were all great questions. I think the thing that we want to keep in mind is as we think about COVID and we think about these mitigation strategies, I think one of the first speakers said these are not COVID specific, and that's absolutely correct. These are things that will increase the indoor air quality, increase the healthy population within schools for decades to come if implemented. And that comes along with decreasing the impact during cold and flu season. But also remember that COVID didn't exist until last year. And so when we talk about its comparativeness to cold and flu season, it's good to keep in mind that we're not looking at them independent. Next year, if we do nothing, we're going to have cold, flu, and COVID hospitalizations. If we start putting in some of these different pieces of the puzzle, we can decrease that disease burden across all of these common things that we see in schools. And so getting to the HVAC question, HVAC versus masks. Masks are very good at stopping an infected individual from spreading, so point source spread. HVAC systems are slightly different because they stop those aerosolized particles. And as we discussed a little bit during the presentation, aerosolized particles are becoming more of a concern as we learn more about the disease. And so when we talk about those, they're different effects and different uses. And so it's not a one or the other, but it's prioritizing the biggest benefit to everyone. And when we talk about masks, if somebody's potentially positive, maybe asymptomatic, or maybe mildly symptomatic and their parents still sent them to school. And they go through something and they're producing aerosols. They're singing, they're ran to class and they're breathing pretty hard. Masks are not effective at stopping aerosolized particles, but the HVAC system is your next line of defense for it. And so that goes with cold and flu germs that get passed around. And so it's not a one or the other, but as we learn more, we're prioritizing HVAC a little bit more, and we're trying to get ahead of it because we keep learning more of an impact from those aerosolized particles and less of an impact from droplets. And that's kind of the sense that we get when we compare outdoor activities to very similar indoor activities. The only difference there, if you're wearing a mask outdoors and playing soccer and you're wearing a mask indoors and playing soccer, you have a higher likelihood of passing COVID indoors, and it's not because of the masks, it's because of the environment. And I think that one of the references in the document that we're going to share with the Board of Health, the PowerPoint slides, and I forget exactly which number it is, but I'll highlight it for them. It discusses that exact nature. As we see droplets become less important in outdoor activities, and given the same circumstances, the only difference would be the environment and the air that you're breathing. So it's volume, it's fresh air, and it's the HVAC's ability to provide similar environments. So I hope that answers some of the questions.
Thank you. Councilman.
Thank you.
Yeah, I have a follow-up question that was kind of prompted from one of the callers. What is your stance or recommendation on an asymptomatic person, for example, children in school, wearing masks throughout, let's call it a 6 to 8 hour day, and then the rest of their life going and making contact with the rest of society and community, the effectiveness of that mask, of course, if you had symptoms, because in your presentation you said that a mask, for example, is a good tool if you are symptomatic. What's your stance on masking for a portion of your day and then having community contact throughout the rest of your day? Any effectiveness to the strategy and comments to it?
I can take this one if you like, Mike.
Yes, please. Hey, Jimmy.
All right, this is Jimmy. Hi, everyone. So, I mean, ideally, a person who's masking in school, what is most effective, and I think you're alluding to this, is that they're masking all around. So if I'm at the grocery store, I'm masking. If I'm anywhere that really is not my household or anywhere that's kind of indoors and I'm around people that are not part of my household, ideally to get, the most protection for myself and others around me, I would be masking in all of those situations as well. So not just the school, which is why the idea of a mask mandate can get a little tricky, because exactly to your point, if there is a mask mandate and people are only masking in school, but they're not anywhere else, then what's the point? However, the people who then choose to mask, we would hope that because it's a choice that they've made for themselves, then they're going to be masking in all these other places as well, giving that maximum efficacy and protection. Does that make sense?
Sure. So what I heard you say.
If we can also just start to wrap this up too. It's
okay. Sure. Thank you. It makes sense. So what I heard you say is that masking a portion of your life is very effective. If you were to mask, perhaps you have symptoms, it would make sense. If you have a reason to mask, in a variety of them, even if you're fearful, could be a good reason, then you should choose to wear a mask. But to mask for a portion of your life, and not throughout the entire day, perhaps isn't effective. Is that what I heard?
Right. I mean, because the other thing is also like when you're looking at how the way that COVID spreads, right? You're thinking about what a close contact looks like. Technically, like when I think about, going to a grocery store, I'm in an aisle for a couple of minutes, somebody passes me by, that necessarily may not necessarily meet the definition of a close contact that gives a person an opportunity to spread COVID-19 to me, as it would if I was sitting in the same classroom with an individual for 6 to 8 hours a day, or whatever the case may be. So ideally, again, yes, you probably should, mask whenever you're outdoors or whenever you're outside of your household in indoor settings. Because again, if you're outside in a park and there's fresh air, we're not really worried about masking at this point in that situation anymore. But when you are outdoors in public settings where you could potentially be around people that are not members of your household, that's where you really want to think about masking. And in order to get that full-on protection, you should potentially consider that. However, if we're thinking about all the other layers of protection, in this case, we might be considering, people that are vaccinated as well. You just have to factor and make that personal decision of what looks right for you in your particular situation.
Thank you. Thank you. And thank you, Fusion Cell. We're going to move on to the next agenda item now, but I just want to wrap up by saying, there were 3 reasons why we contracted with Fusion Cell, and we sent a letter, and a white paper over to the Board of Education. And we need to keep those 3 reasons in mind. One of them was the Americans with Disabilities Act, which we learned in federal court was in fact going to be applied to actions taken by this board and likely actions taken by the Board of Education as well. And we need to be certain that we're doing the analysis necessary in order to ensure that we are meeting the requirements that would be and have been enforced in a federal court for COVID response. Second, we wanted to better understand the psychological impact that masking can have on children in particular, but also generally. And third, there was a public health component of it. Really, 2 and 3 are subsets of number 1. The Americans with Disabilities Act, we know, applies to this, applies to actions we take, applies to actions that the school board takes, and so we need to be sure that we are doing the proper analysis and putting the thoughtful consideration into actions that we take, and that is why Fusion Cell was so important to us, and they will be important to us moving forward. Thank you, Fusion Cell. We are going to be in touch. There's a lot of follow-up work that we need to do. I would now like to move on to the ever-patient Dr. Nicole Comstock, who is with the Colorado Department of Public Health and Environment. And she was going to give us a briefing on Omicron and sort of what's happening in Colorado, what we should be thinking of as a Board of Health, and any other advice that she may have. Dr. Comstock, you are live.
Thank you. Hi, everyone. My name is Nicole Comstock. I'm actually not a doctor, not a PhD.
I thought you were. I apologize.
No, that's okay. Just don't want to be misrepresenting myself here, but I'm the interim branch chief of the communicable disease branch here at CDPHE, and happy to be here today to talk to you about the new Omicron variant that's emerging. So this first map is showing the emergence of Omicron worldwide. Just 2 weeks ago, we only had counties lining up in Southern Africa, and you can see here the countries in blue are where Omicron variant cases have been detected, and you can see it spreading quickly through the world. Here in the US, as of yesterday, there are 19 states who have detected Omicron variant cases, including Colorado. And I imagine this map will start lighting up with most states probably within the next couple of weeks. Here in Colorado, we had our first Omicron case detected last week in an Arapahoe County adult, the second case in a Boulder County adult, both of whom had travel histories to Southern Africa during their exposure period. Both were isolated and recovering and did not have serious illness, did not require hospitalization to date. Yesterday, we detected Omicron variant in a wastewater sample in Boulder County, which likely indicates some level of community spread in Boulder County. It's hard to interpret what that result means. It just shows that there's likely some level of community spread in Boulder County. So a little bit of background on this variant. Omicron variant, the kind of technical name for it is B11529, was identified in South Africa at the end of November, designated as a variant of concern by the World Health Organization on Friday, November 26th. The first samples that were collected of this variant were collected in mid-November in some Southern African countries. But since then, there's been a rapid increase in cases throughout the provinces of South Africa and surrounding countries. This variant has multiple mutations across the genome, more than 30 in the spike protein, which is a protein that allows the virus to attach to human cells and invade and cause illness. So as kind of alluded to earlier with the fusion cell presentation, there's a lot we don't know about this variant, just like we just don't know a lot about COVID in general. We're learning as we go along. But potentially, this variant is demonstrating increased transmissibility, so easier spread from person to person. And it looks to have the ability to evade the immune system. There's evidence in South Africa that people who had prior infection with the Delta strain were able to be reinfected with the Omicron strain. And there's some evidence that vaccine may not provide as much coverage. However, vaccine is still recommended as one of our best tools to protect against COVID infection. In fact, today, Pfizer announced that 2 doses of their vaccine may not be sufficient to protect against infection against Omicron, but their initial lab tests do suggest that 3 doses offer significant protection. So this is highlighting the importance of boosters, which are now recommended for everyone over the age of 18. So there's many remaining questions, about Omicron, the spectrum of illness, how severe it might be, and this is why we are prioritizing case investigations here in Colorado and really nationwide to try to better understand how this variant is going to act. So what are we doing to look for Omicron in Colorado? First is diagnostic tests. Many tests in Colorado, including the tests used at our state lab and at the majority of our community testing vendors, are performed using the Thermo Fisher TaqPath combo. This particular test can detect Omicron variant. It's a PCR test. We are prioritizing for sequencing at our state lab and asking testing partners to do the same, especially if we come across a case who has a travel history or contact with a known Omicron case. We are putting those samples kind of on the top of the queue to get sequenced so we can better determine if we have ongoing transmission here within the state. All clinical labs that they are doing sequencing need to report those results to us, so we should be getting those in a timely manner. Clinical labs that aren't doing sequencing are required to send positive samples to our state lab where we do the sequencing. And usually that turnaround time is around 10 to 14 days from when someone has a positive test. So it takes a little bit of time for that sample to get packaged up, sent to our lab, put into the queue for sequencing. And the sequencing itself takes a couple days to run and analyze. Let's see, our sequencing methods have been updated to make sure that we are detecting Omicron in patient samples. We have wastewater surveillance in our state, which looks for genetic markers indicative of variants. And we can detect Omicron, obviously, since we detected one in Boulder County yesterday through those samples. We're also conducting travel monitoring per CDC guidance for monitoring travelers who spent time in 8 Southern African countries in the 14 days prior to arriving in the US. And we're monitoring these travelers for symptoms, connecting them to testing. So they get tested with a PCR test on days 3, 4, or 5 after arrival in the US, and recommending quarantine regardless of vaccination status for these travelers. Just one note on our wastewater surveillance. The map on the left here is the Colorado map of the utility areas that are participating in our wastewater surveillance efforts. So the colored blotches on there show the kind of coverage of our wastewater surveillance. We are trying to grow this program. You can see in Douglas County, we have parts of the county covered: Roxborough Park, Lone Tree, and kind of northern Parker area here. Those wastewater utilities in those areas are participating in the wastewater surveillance. This program is looking for additional utilities to participate. So if any other utilities in Douglas County might be interested, we'd certainly be happy to talk to them and describe the program in greater detail. So Omicron does not come from, it's not a variant derived from Delta. So I know this is hard to read here, but just to kind of show you the map here, the dendrogram, all the green here are Delta strains. Omicron is down here in this red that emerged in late November of this year. So the closest evolutionary connection to Omicron is to viruses that were circulating in mid-2020. The exact origin of Omicron is not known, but it indicates, if you kind of trace this red line back here, that it was circulating to some degree for some time prior to really taking off in South Africa in November. So here's what's concerning, data out of South Africa in the Gauteng province, which is this red line here. You can see they had a pretty substantial outbreak of COVID, and this is largely Delta variant this summer. And then really in that particular province and countrywide in South Africa, they were really down to pretty low rates as they kind of entered their summer months. But you can see here this red line taking off really quickly, and that was really driven by the Omicron variant emerging in November. This chart, I think, also shows it pretty nicely. Here in the green was the Beta variant that was circulating in summer of their winter, our summer in 2020. And then it was replaced briefly by this gray Alpha variant, replaced pretty quickly by the red here, which indicates Delta variant. And then we had Omicron, the B11529, emerge here in November in South Africa. And you can see it's quickly taking off and replacing Delta as the predominant strain in that country. So we know that the variant has infected fully vaccinated persons. Not much data other than what came out today from Pfizer about third dose offering significant protection. We don't have much other data at this point showing the effectiveness of the boosters in preventing or lessening the symptoms for Omicron infection. As I mentioned, persons who have been infected and recovered from Delta variant have been reinfected with Omicron variant. We're collecting data fast and furious. Worldwide, nationwide, in Colorado, when we have cases on the spectrum of signs, symptoms, and severity, there are some initial reports that symptoms might be milder, but we need to take those with a bit of a grain of salt. A lot of the cases, especially in South Africa, were detected among younger adults in university settings. So that's the population that just overall doesn't have as much risk for developing severe infection generally. South African public health officials have not reported an increase in the proportion of hospitalizations, ICU admissions, or deaths, so that's good news so far. And anecdotally, there's reports of patients feeling intense fatigue. However, they're not reporting the loss of smell or taste, and otherwise symptoms just reporting as mild. But again, we're viewing this with caution. We don't know what it's going to look like if we see Omicron in a high-risk setting, such as a nursing home or other type of long-term healthcare facility, and how that might impact infections and severity in those settings. So overall, and again, this is a moving target, but vaccines, we expect them to remain effective against severe illness and death, but the actual protection that they're going to offer against Omicron is currently being studied. The monoclonal antibodies that are used early in illness to prevent severe infection, we don't have any Omicron virus-specific data at this time. And same goes with antivirals, unknown how effective they might be, and studies ongoing there. So I'll just end with a few slides on what we're asking local public health agencies in Colorado to do around this variant. So first of all, we are notifying local public health agencies when a case is detected via sequencing at our lab, if we get sequencing results from a clinical lab, or for finding any wastewater samples that are positive. Our first call, or close to first call, is to the local public health agency to let them know what we found. Sequencing information is entered into our disease surveillance system, which is CDERS or Dr. Justina. And we have a data portal for local public health agencies that has a sequencing report that can be pulled. And we've shared that with Douglas County and the Jogan staff. Traveler monitoring is currently being conducted by staff here at CDPHE. And again, we're at this point only monitoring travelers who have arrived from the 8 Southern African countries that were mentioned earlier. Travelers are entered into Dr. Justina, so there's situational awareness at the local level if they have a traveler that's being monitored. For case investigation and contact tracing, we're asking local public health agencies to prioritize case investigation and contact tracing for confirmed Omicron cases or cases that they come across that might have a recent travel history to an affected country. We do have a shortened interview form that many agencies use when we're in a surge, which we are still currently in a surge with the Delta variant in our state. We are asking our local public health partners to use the full long interview form so we get as much data on our cases as we can to better understand the spectrum of illness. We're asking local public health agencies to interview all close contacts. And as far as isolation and quarantine for Omicron cases, we're just following our normal guidance that we've put out there. We are not recommending formal orders or requiring formal orders unless there's a case associated with a high-risk situation, such as a case that might work in a nursing home or some type of congregate living setting where we'd be worried that an outbreak could occur. If testing is needed for contacts to Omicron case, we have resources for that and are asking local public health to contact their assigned EPI team. And for outbreaks, if there are Omicron outbreaks in any residential healthcare facilities, like nursing homes, assisted livings, those type of facilities, our team here will lead those outbreaks, but normal processes will be followed for all other outbreaks. Included some resources here, some links to places to get some good situational awareness about how the situation is evolving. And that's it. I'm happy to answer any questions.
Thank you. That was helpful. Are there any questions from board members? Anybody? Commissioner Thomas.
This is just a quick comment. I thought what was really helpful is when you were talking about what was reported as the symptoms and what was going on with Omicron, is that you said extreme fatigue, very mild symptoms, and no loss of smell or taste. Is that correct?
That's right. That's some of the early evidence. It's probably more anecdotal that we've seen come out of some of the countries that were affected in earlier in November, late November. Systematically, there's a big effort to collect that type of information on all confirmed Omicron cases to better understand the spectrum. But at least initially, it's looking like it's a milder illness compared to what we're seeing with Delta.
Thank you. I think that's reassuring to share with our population. So thank you, ma'am.
Commissioner Teal.
Hey, thank you, Mr. President. Ms. Comstock, I wonder if you could, if it would be possible, could you share that slideshow with the Board of Health, or more specifically, could I ask you to at least set the, on your last slide, you had the press releases. I take it those are probably hyperlinks when you put them into your PowerPoint. Could we get some of those hyperlinks so we can study them, study the content once the Board of Health is adjourned?
Yeah, you bet. I've been working closely with John Serbic. I'd be happy to email him a PDF of this if that works, or to whomever might be easiest to send it to.
Fortunately, he is nodding, so yes, if you could, please.
Okay, we'll do that.
Well, thank you, Ms. Comstock. One quick question. It sounds like you're looking for more data in order to better assess the impacts of the new variant. When will you have the data? Will you be able to more confidently say, we understand the impact, we understand whether it's more severe, less severe? What does that look like?
So of course, so far in Colorado, we have, a very small population to study here, just 2 cases.
Yeah.
We collect data and share that with the CDC, and they are aggregating data from cases from across the country. So I suspect the CDC did put out a science brief outlining what they knew or know at the time about Omicron on December 2nd, so last Thursday. We haven't seen an updated one at this point, but I know we send our data to them. They're aggregating it across states I just don't have a target when we might target date when we might see that.
Okay. Well, Dr. Fielding, I'm sorry.
Yes, I'm sorry. When you had mentioned that, Mr. President, it brought up a question to me. To really get a handle on the prevalence of this variant, what percentage of cases of COVID in Colorado is actually sequenced?
So we are, every positive that we get our hands on at our state lab, whether it's a positive PCR test, and again, these are just PCR tests, we need to have the actual specimen with viral material on it to do the sequencing. So every positive in our state lab, PCR test positive is sequenced, as well as whatever specimens we get from clinical labs that they send to us. And they should be sending everything or close to everything.
Everything in the state.
Every PCR positive test, there's a public health order where that's in place, where those need to be sent to our state lab for sequencing if the clinical lab is unable to do the sequencing on site.
Okay, so at this point, that would indicate that the Omicron variant does not have a high prevalence in Colorado.
Right. Yeah, we are definitely still 99.9% Delta. So we can't forget that, that's our strain circulating. That's where, what we're seeing right now. And it may take some time for Omicron to gain some momentum. It's hard to predict how soon that might be, but what we're seeing in at least South Africa was it was gaining momentum pretty quickly. So it could take, several weeks, maybe several months before that strain might outcompete Delta.
Yeah, this
or
is
maybe it won't. We'll have to see.
This is a very interesting pattern because it reminds me very much of influenza, how the strains evolve and each one supplants the next one, which would tend to make me believe that COVID is going to be there for a long time.
Yeah, we suspect some type of endemic level of COVID long term.
Yeah.
Councilman Bracken.
So, my question is, so the antigen test will not detect, just the PCR test will detect Omicron, is that right?
I believe antigen tests, at least some of the data I've seen from some of the test manufacturers, they do indicate that the rapid antigen tests are effective at detecting Omicron. I don't know if I can say that across the board. I haven't looked at every antigen test out there in the market, but at least some of them are indicating that they are effective at detecting Omicron. You just, those type of samples, you may not have material left to amplify to do the sequencing on. So in those tests, we aren't necessarily getting all of those sent to our state lab. A lot of those are done, on-site rapid tests, not necessarily something that's sent to a clinical lab for testing.
In your experience, how differentiating is the antigen test? I know the PCR test is more defined and accurate, but how is that test at differentiating between SARS, COVID-19, influenza, and those types, or are you seeing that they don't differentiate? And if you don't have the answer, that's okay, because I know it wasn't part of the subject matter.
If I'm understanding your question correctly, the antigen tests for COVID detect, an antigen specific to, that's produced by the virus itself. So there shouldn't be a lot of cross-reactivity between COVID rapid antigen tests and the rapid antigen tests you might see for influenza or other viral respiratory pathogens.
Okay, I wanted your opinion on the testing type and any crossover, so thank you.
Well, thank you, Ms. Comstock. We appreciate your time, and we may have you back on occasion. So thank you, and it was very helpful. And we will go to now. Let me see if there's any comment from anyone in the audience. No, none in the audience. Do we have any online commenters?
Thank you, Mr. President. I have no online comments.
Okay, well, Ms. Comstock, thank you very much, and we'll move on to the next agenda item. See, we were, the next agenda item is an update on contracted COVID-19 response services. Mr. Surbeck and Mr. Dietrich of Jogan Health Services will be providing that briefing.
I'd just like to start by thanking Nicole for being part of this on short notice. As you know, we work very, very closely with her, and she's been a huge benefit to our program. So I just thank her. I believe Dan's on. I'll defer to Dan, and then I'll speak subsequent. Dan?
Hello, this is Dan Dietrich with Jogan Health. I am the CEO and president of the company. We've been working together under contract for the contact tracing, case investigation, and epidemiology work together with you guys for almost a month now. And we're really feeling good about the way that the systems are operating. We have a really strong team in place. And I'm not sure from your perspective or the background if there was detail into our company and the ties to the local community, but people may or may not know I'm actually a Douglas County resident, and I have 9 children. So we have a large family, and we live and work in the community, and we're really appreciative and honored to be able to have this opportunity to work in the community itself. I have Amy Abel here with me as well, and she's actually the program manager itself. But the information we have as far as performance and things, there's a 90% metric for contact. And our team from inception has been able to exceed that, with many days having 98 to 100% of contacts occurring. And that's as cases continue to rise. And proactively, we have a lot of additional resources in place to be able to effectively handle some of these surges. So we're continuing to see an increase in cases. There's a lot of outreach, and as you heard about, from the update from Ms. Comstock there, that we anticipate that this new variant will continue to grow, and it's going to put a very heavy demand on contact tracing, especially if there's you could see from the graph that was shown that this overtook Delta really quickly in South Africa. And if we have similar results here and it's more contagious, we've all seen some of these articles that talk about the effects on the under 5 population and things. Our stance and our position in our duties and responsibilities back to our community is to be prepared for whatever's coming. And we've done a lot internally to plan for these variants and the potential effects itself. So with that, I'm going to open it up to you guys for any questions in that specifics. This is sort of a broad scope approach to this section here, but we have all of the details, the data, the information into whatever level you guys would like to hear from our side.
Thank you. Mr. Surbeck, you have anything to add on, or any other comments you would like to make?
Well, I would just say that partnering has been extremely favorable. Starting out with nothing and creating an effective program is a pretty tall order. And as Dan mentioned, the case investigation is going extremely well. We've encountered all sorts of setbacks, I would say, from the supply chain as it relates to phones and some of the things that had been ordered well in advance. And so we've had to create workarounds and so forth. But the staff has been extremely dedicated, and Amy, who he referenced as being his project manager, has worked very collaboratively to make sure that no one is staffing that doesn't share these same values. If they don't perform, they don't stay. And my hat's off to them, because they've been subjected to a good deal of hostility and frustration and so forth, and they maintain positive attitudes. They work on their script constantly to make sure that they're providing accessibility, they're conveying compassion, and that they're being very sensitive with this very important body of work. So, you know, they've granted me an opportunity to provide on-site assistance, and we're therefore able to better provide back to the state confirmation as to the body work that we are creating, and make sure that we get all the deliverables that are necessary so that Douglas County does receive full compensation reimbursement for these services.
Thank you. Board members, are there any questions for Mr. Dietrich or Mr. Surbeck? Commissioner Teal.
Thanks, sir. Actually, this is something that Mr. Surbeck has heard, but Mr. Dietrich, you know, I know, thanks so much for stepping up to help us out with this, with your company, with your organization. It was very important to me when that handoff happened from Tri-County and you guys came on board. I was very pleased to hear of the 90% metric of coverage that you guys have set, and as you said, you've exceeded. It was less important for me that things be efficient up front, so much as that coverage be near as 100% as humanly possible, knowing that efficiencies and some of those logistics hurdles that we had to overcome with you guys were achieved over time. So I'd say my vote on this one is please keep working on efficiencies, but we've been subjected to months and months of hearing over and over again from other agencies that it's so difficult to do contact tracing. It is so difficult to handle this workload. It was very, I was very happy to hear you guys take the coverage of transactions as your primary requirement, knowing that efficiencies will come and will follow. So please keep up the good work. Please keep the data flowing. Please keep the information flow two ways. Let us know what you guys need in order to continue to do a great job.
Thank you.
Commissioner Teal, I guess to speak to that, we've been working with epidemiologists to provide, we're not there yet, but to provide a snapshot of daily activities that could be provided to you that don't cause any problems, that would be able to give you a more granular understanding without violating any type of HIPAA component.
Mr. Surbeck, you know how much I appreciate you saying that, because you know that that's one of the things that I've been asking for the last several weeks. One other thing I'd like to put on your reporting horizon, and I realize I'm kind of breaking with the order of the agenda here, but one of the things that impressed me was the comments that we did receive from Fusion Cell pertaining to the 90 days of higher certainty of natural immunity following an active infection. The president has been looking over my shoulder as I've been typing away furiously on the computers that here at the dais, because I've been trying to see where any source that's actually tracking infections, positive cases in the last 90 days, whether it's CDPHE, whether it's Tri-County. And when I think about the role of a lot of public health boards in providing guidance, levels of certainty in direction to the public and suggestions to the public on how they can look out for their own good health, we don't seem to be tracking, I can't find anybody tracking cases in the last 90 days. In terms of, are we at a hot time? Perhaps not a hot time for infection. I think we are getting those reliably. But in terms of a hot time when the immunity, the natural immunity, because of cases in the last 90 days, may be higher in the jurisdiction. So I'd like to put that, add that as one more thing, John, to ask in terms of reporting up to us as an additional metrics that we can start tracking and see if there's positive results that can be derived.
Amy, can you make a note of that for Jared?
Absolutely. And I think in the background, that was part of our new metrics that we're building in the background. That will be part of that eventually. And I think Jared has some of that already. Then I can try to get that sent to you possibly by tomorrow. It may not be totally complete, but it at least has, you'll have something to look at.
Well, our rolling matrix that we've been capturing, we could provide a longer kind of lens on those, right?
Yes, correct.
Perfect. Thank you. Any other questions? Anybody? Well, thank you. And Ms. Dietrich and Mr. Beck, I think you heard me. Discussions with Fusion Cell moving forward, I think would be a good idea. We're going to be setting up some times to meet, and so we can start talking about intervention strategies and we want to make sure that we're all sort of singing from the same hymnal on this. So it's important. And I think going back to, I think Commissioner Teal's point is important. Natural immunity is something we really need to address. It's a real thing, and we need both in our strategies and in our tracking, I think is a great idea to do. So that will be something I think Fusion Cell will be able to help us with, and we'll look to that moving forward. Please.
Let me just say that we've had very high-level contact with school district, and we've set up two kind of recurring focus groups, one more high-level and one more granular, that we are committed to moving forward. And Jogan's a part of that, and we will be using the resource to make sure that we're able to capture the succinctity of the message that we need to be able to articulate, because we have so many constituents that we need to provide feedback to and guidance, and we want that to be uniform. We want that to be something that doesn't pit one vendor, or not vendor, but consumer against another consumer, so that we're able to provide good guidance, sound guidance, and consistent guidance. And Jogan will certainly be a key player in that process.
Great. Thank you. First, any comment in the audience? Okay. Do we have any online comments?
Yes, thank you, Mr. President. Eco Browning, you're unmuted. Go ahead. Whoops. Now you are.
Hello, Board of Health. This is Aiko Browning. Hi, this is Aiko Browning, constituent in Highlands Ranch. I have some questions for Jogan Health. So specifically, what is the scope of the contract for Jogan Health? Is it purely contact tracing? It was mentioned contact tracing and epidemiology. And what exactly does that entail? I would like to know, what is Jogan Health's public health expertise and background, because I could not readily determine that from their website. What are the individuals in this organization's public health background and expertise? And are you hoping to provide COVID incidence, hospitalization, hospital capacity dashboard tracking like Tri-County Health provides? Thank you.
Thank you.
So absolutely, I can take part of that. John, did you want to comment related to the contract?
Hold on for 1 second, Mr. Dietrich. Mr. Pratt.
Yeah, just a point of order. We may want to, if there's any other public comment, we may want to hear that before we respond.
Thank you. That's exactly right. Is there any other public comment?
I have no other online public comment.
Okay, so why don't we handle the question this way? Mr. Dietrich, if you've got some responses, that would be great. And John, if you have briefly something you need to add on to that, that would be, why don't we do that? So Mr. Dietrich, I will turn the microphone over to you.
Sure, absolutely. So Dr. Browning, our company is purpose-built specifically to assist local public health agencies and states in the COVID response. We work in 5 different states, and large scale. We provide hospital surge staffing. We provide turnkey vaccination operations statewide. We do testing. We do monoclonal antibody treatments. We do private data entry for patient data relative to vaccination in databases, and we do this project here specifically. We have multiple staff members within our organization of a total of around 3,100 people right now. Almost all of them are clinical, so RNs, LPNs, CNAs, medics, things like that, that are in the field where they have backgrounds specific to contact tracing. We've activated or mobilized those to be in the project lead side. And then we've connected and recruited with either industry contacts or through direct recruitment epidemiologists. And then on our case investigation team, we've gone to a higher level and put clinical people in there. So either RNs or LPNs that have background and experience to do the case investigation versus just training somebody from scratch. And then, like I mentioned before, we've filled the team to the specifications. Obviously, you have potential for turnover and things like that over time, but we manage that by the addition of float staff as well as backup staff. So these, again, we have float staff for contact tracing, and then we also are identifying additional clinical staff from our other teams that can be trained and ready to come in line should things be affected either from surge or illness in the future.
Thank you, Mr. Dietrich. Surbeck,
I
anything to add
guess
on?
just to kind of build on what Dan said, predominantly a supervisory component is facilitated in a team fashion by epidemiologists and by registered nurses. In addition, all the people that are being utilized have gone through CDPHE's training and have been cleared security-wise to use the associated platforms. So they've been vetted as employees and then also vetted to use the state systems. And then, ma'am, speaking to your question as it relates to the service delivery that Jogan's providing in this specific contract, it relates to what Tri-County referred to as the COVID response work, specifically identifying contact tracing, case investigation, and outbreak investigation. And so that's a primary scope of work. There's collateral pieces that are associated with that, but those are the primary components. And of course, CDPHE is a prime partner with us in this process as well.
Thank you, Mr. Surbeck. If there are no other questions from the board members, we will move on to the next agenda item. An update on the hiring process for Public Health Director. Ms. Leary. And thank you, Mr. Dietrich.
Thank you all.
Okay, thank you. And I'll try to make this as quick as possible. Just wanted to give quick updates on the Public Health Executive Director recruitment that we are working with the firm CPS HR. We launched this recruitment on the 13th of November. It is going to close on December 17th, and it's sort of a soft close. If the position doesn't get filled, we will, of course, continue to keep it open over time. But we anticipate that we are in pretty good shape. We have 39 applicants as of today. Of those, we would say 10 are highly competitive applicants. None of them are medical personnel. They would all fall underneath that administrative perspective, so similar to other local health agencies in the metro area like Larimer and Boulder and Jeffco, El Paso. We have folks from all over the country, all over the country, from the East Coast to the West Coast, some Midwest, and I believe one here in Colorado locally. So CPS HR is going to close that recruitment, soft close on the 17th. They will be then conducting the remainder phone interviews prior to the holidays, so that would be prior to Christmas Eve. And then they will be preparing and delivering the resumes of these, what we would call semifinalists, to the Board of Health, each of you. We will get them to you in an electronic fashion and a hard copy fashion to whatever address you'd like us to get them to. The 7th of January is a Friday. So you'll have those to be able to review. Now, you'll see the next couple of buttons on the slide here have bullet points where it's referring to a meeting that the Board of Health had previously scheduled on January 12th. It sounds like, based on your earlier decision about meetings, that would be going to the 13th, which is a Thursday, I believe the second Thursday of the month of January. So our CPSR recruitment individual, Andrew Nelson, will be coming out and reviewing what I would call Team A and Team B with the Board of Health. He will basically cull down to maybe 6 candidates in 2 separate buckets to be able to provide you with information with respect to the phone interview questions, comments, information he's derived, his notes, as well as walking you through the resume application process. What I am going to request is that on that date of now, January 13th, when he does come into town and is looking to do a in-person candidate review with you, each of you as board members, we would require about a 90-minute time frame that would be likely done in executive session, but because we'll be talking about all of these different candidates and their backgrounds and that kind of thing. And so I'd like to see if we could get that, Mr. Benevento, onto your agenda for that day, because that will be a pretty significant component of that meeting. And then finally, at the end of that meeting on now the 13th, you as the board will be able to make direction, provide direction to us with respect to finalist interviews. So it may be that the finalist interviews that you choose to move forward in that final round could be in-person interviews, or we could also do phone interviews, or not phone interviews, video interviews first, and then bring 1 or 2 final finalists in a couple weeks later in person. I think it will really just be determined at that point based on what the Board of Health would like to do, how many candidates you seek to bring in. You may have just a couple, 1 or 2, that you say these are the top 2, and we're ready to bring these folks in and meet with them in person for a period of time. Alternately, you could also have potentially 4 or 5 candidates that you were really interested to see, and it might be that you want to, at that point, utilize a video type of component before having them fly in. So that's where we're at. I think the process is working. I think Andrew, in speaking to him yesterday, feels really good about the quality of candidates that we've been able to attract. And I don't think anyone should be surprised by that, considering the organization that we have here in Douglas County and the community. So with that, I'll ask if there's any questions or anything else I can provide.
Are there any questions? Okay. Well, excellent. Thank you, Ms. Leary. I appreciate it. The final item is a transition management update from Ms. Fleming.
Thank you. Well, Marlene Fleming, again with County IT. Never been called a closer, but here we go. Let's see what we can do. So just a couple things I want to point out. I have a brief presentation to go over. Great discussion around the COVID-19 protection services. I just want to point out that some team members that are also working on the public health program are supporting that very important effort and anything that's related to that. So there is this huge effort upon us that we are very focused on. So let's jump in. Really quickly, I'd like to provide a program update, some perhaps revised program success factors, and then some upcoming activities. So I want to give you a quick view as to what we've been working on and what are some upcoming activities. So really quick here, the program team organization. I showed this at last meeting we had. I just want to point it out again that we are looking to create those functional areas on the top there, such as community health promotion, nursing, environmental health, and EPR. And then we have supporting departments. Every member that county staff is involved in that, they step in every day to help support this effort. So as far as what's been going on, this is a very busy slide, as you can see. What I wanted to point out here is the respective work streams that we have going, and whether it's nursing, nutrition, community health promotion, environmental health and such. And we have launched into an effort around workshops. The workshops, a very deliberate part of the methodology that I discussed at the last meeting, to dive into these services and really understand what's being provided, what the details around each and every services that currently Tri-County provides for Douglas County citizens, as well as the documentation that's critically important that we capture. So you can see there we've covered for nursing, nutrition, and community health promotion. We launched that set of services. We've completed the first two and are wrapping up the third, community health promotion, very shortly here with the documentation and the deep dive that we're doing in each one. As far as the RFI posted, you can see today it's not 3 RFIs, it's one that contains these specific services that we've put out there to get requests for information to help us get a sense of how can these services be provided. Continuing on environmental health, that is a pretty sizable area there that we are beginning and have scheduled workshops. And again, the same concept, we are in pretty close communication with CDPHE, establishing those relationships to make sure that we understand how is the not only transition, but the details behind the services being provided, what is core, and I'm going to go into very quick detail into each one just to give you a sense. Again, COVID-19 protection services and vital records, the main areas that we're focusing on. As far as, don't want to drain this slide, what I want to point out here is the objectives of the workshops, as I mentioned, better understanding of those services, start to begin to classify those services now that the CHI is available, the priorities, right? We have a lot of moving parts here. We have the CHI, we have the FIP soon, we have the advisory committee information, and we have what Tri-County has provided us. So it's really a synchronization of that data and understanding what are those services. And you can see here, we are talking about what are core services, key roles around that, feasibility, whether these should be in-house, outsourced, and all this information, and certainly understanding the funding stream, which is pretty, in some cases, elaborate with CDPHE, the grant mechanisms and such, and also logistics around what would it take and interdependencies. We have a spreadsheet going for every single service that we've covered. They're being classified, and it's certainly opened up the eyes of the team big time in terms of that the knowledge and greater understanding as to what we're dealing with here. I don't want to drain this slide. It's hard to see. The main thing I want to point out with these diagrams, spaghetti diagrams, is to say that we are, with the great work from our Dr. Laura Kessler and part of the team and others, we are taking each group of services, and the key here is to really understand the interdependencies. We are finding that most of these, they really don't stand alone. When you take EPR, I mean, that can go across the spectrum, right? So it's really important that we understand those interdependencies and that we effectively identify how we would offer that service and leverage other areas. So that's been a very important objective and key in identifying these services. So we are mapping the data, we are making the interdependencies, we are making assessments, we have, I want to say, experts. We're using Tom Butts, which this board is familiar with, weighing in with his expertise. We're using CHI, CDPHE, Tri-County personnel. So it's really very collaborative, and more importantly is to get good information to capture and for us to be able to provide recommendations to this board as to what are we seeing, how are these benefits formed. Moving on really quick, high-level timeline. We are in the first part. You can see November timeframe. We were focusing on the COVID-19 protection services. We are in the middle of the workshops that is intended to go through the middle of January. At the same time, we have some tracks that are running, which we're calling solution assessments, solution evaluations. In the area of environmental health, we have an opportunity to look at systems, technology to be able to carry those functions that are well known. That's an area that is just better understood to many areas that we're working with. So here, the intent is to work through the workshops, solution assessment, be able to bring recommendations to this board, and to have a rollout schedule that hopefully June 1st, we're able to have, or prior to that, of course, but June 1st target of deployments. You know, this is 123 will be here before we know it. This is a very short runway to put a benefit. So we are looking at subsequent deployments where it makes sense and proceed on, whether they're in-house or outsourced. In terms of success factors and program risk, really quick here, just tracking what's happening with Tri-County. You know, what is really happening in terms of, and the impacts it has on this program, have that as a program risk. The other one, Larry just spoke about the hiring of the public health director, key to this program. Securing qualified candidates, right? As this market is very tough, in making sure that as we go through the workshops, we are identifying roles and ensuring that we have job descriptions and really be organized and in a position where we can act on the recruitment component when we need to. The area of business management and grant through the COVID-19 protection services we've discovered, we sort of knew, but it has solidified our thinking that that is a critical area to this public health, our ability to organize around this financial infrastructure for the revenue stream with CDPHE, the reimbursement process, and to not only know it well, but be able to execute on that. There is a process, and that's really, you know, as you can imagine, key on ensuring that that is in place. Facilities, space, as we continue to bring in public health staff members and hire them on, making sure that we have the facility in place. And then last but not least, the ability to pivot as conditions change. Key, right? I mean, constantly, we are finding information every day, and we need to make sure our plans include that. And just kind of to wrap up, upcoming activities. I mentioned the workshops, what is going on there. Our intent is to run through all the work streams, all the respective areas of a public health department. And we've completed some, we have some to go. And we're also including areas that are internal county focused, like admin, finance, budget, working with Martha, Andrew, and others to ensure that a lot of those services can be leveraged in the public health department. I mentioned the environmental health solution. We are managing a solution track. There's two systems that, one is health space is what CDPHE uses. We are beginning to evaluate both so we can organize behind that. It's really important to have the technology, as you can imagine. The RFI was mentioned. That went out today, and we're monitoring the activities, question phases, and things of that nature that we need to keep an eye on. The roadmap, continue to develop this service rollout roadmap simulation. So what I mean by that is, I already spoke about the synchronization of these other artifacts, the CHA. The FIB advisory board, all those materials need to come together, as I mentioned, but that really leads into the roadmap. I'm calling the roadmap is this rollout, right? To be able to say what is going to be offered first, second, third, concurrent, subsequent, whatever the rollout plan is. Very important to define that, and we need to be able to organize around what that looks like. And a lot of the workshop and the information is feeding into that deliverable. And then the technology, right? There's many areas, whether it's vital records, grant management, data migrations from Tri-County, being able to have a good understanding of how do we get our data, how do we feed these systems that need to perform these functions. Data is key. So we're identifying the respective areas around the entire program and just continuing on to manage. These are upcoming activities. So the team is full steam, busy. We are going full steam. There is no stopping. And I think it's wise that we operate with that sense of urgency at all times. I will answer any questions or comments.
thank
Sorry
you.
if I was rushed. I just want to get you out.
No, thank you. I appreciate that, Ms. Fleming. I just want to comment, Commissioner Thomas and I were smiling when we saw your timeline, and we noted at the end of that on 123, you have 2 checkered flags, and I think we had the same thought. You know, that's not the end, that's the beginning.
Right.
It should be a go flag, not an end flag. So,
Yes.
you know.
Correct.
Thank you. Are there any questions from the board? Commissioner Thomas.
Marlene, I just have one comment. I've worked with you and I've seen how you work. And when one of your employees was sick, you spent time with him. So that tells me that you have a heart to get this done. And I think what's really unique is that when we are building this brand new health department, correct me if I'm wrong, but you're also going to be building a brand new tech system. All this technology is going to be new for databases and everything else. And I've heard other people on boards of health saying, boy, we really envy you. We wish we had this opportunity to just build our own data system, our own technology backbone. And I've known you for a long time, so I know that we're in good hands. Thank you.
Thank you, Commissioner Thomas.
Any other questions?
Questions?
Anyone else? Well, thank you very much. And I was remiss, I think, in the last one we skipped public comment, but is there anybody in the audience that would like to comment? Is there any comment online?
Thank you, Mr. President. Dr. Browning would like to make a final comment this evening.
Sure.
Okay.
Thank you.
You're
Thank
unmuted,
thank
Dr.
you,
Browning.
Board.
Go ahead.
This is Aiko Browning. I would like to share a quote from George H.W. Bush from his signing of the ADA. And the quote is, "This act is powerful in its simplicity. It will ensure that people with disabilities are given the basic guarantees for which they have worked so long and hard: independence, freedom of choice, control of their lives, the opportunity to blend fully and equally into the rich mosaic of the American mainstream. Legally, it will provide our disabled community with a powerful expansion of protections and then basic civil rights. It will guarantee fair and just access to the fruits of American life, which we all must be able to enjoy." So I would like to implore the board that, in the spirit of allowing the disabled community, the elderly community, folks with special needs to participate fully in society, I would urge you to reconsider your extreme libertarian position of masks being optional. This effectively discriminates against folks that are at higher risk of bad outcomes, including the elderly, including the disabled, including those with special needs. And I also wanted to comment that we didn't hear anything in today about the hospitals being full, about Douglas County ICU beds being at 100% capacity 2 days ago, and the Douglas County inpatient beds being at 99% capacity, which I pulled from Tri-County Health because I don't know where else to pull it for because there's lack of transparency as to where these data are being obtained for Douglas County. So I would like to implore you to please, in the spirit of the ADA and helping the most vulnerable and marginalized amongst us to achieve their highest potential and fully access the American dream, to reconsider the masks being optional aspect of your philosophy. I appreciate that you brought Cell Fusion in and they have all these strategies, but we don't have any of these in place. It's just, hey, masks are gone. And to me, that is unacceptable. Thank you.
Thank you. Is there any other comment?
Yes, I do have another general comment from Robert Marshall again.
Okay.
Mr. Marshall, you're unmuted. Go ahead.
Okay, this is Robert Marshall from Highlands Ranch again. Can you all hear me?
Yes, we can.
All right. This is not meant to cast aspersions on anyone, but I want to reemphasize my concerns about what seems like a good old boy operation that happens down here in Douglas County. I put in the core requests after the last meeting, and there is no record of any disclosure with regards to Ms. Benevento working in the law firm. Again, I got a response back that said there was a verbal agreement with the president of the Board of Health that she would not be engaged in any of these matters. I've never had someone come back in a FOIA request for the federal government or a CORA request for any state or local government where they come back and don't just give the documents or not give the documents, but have to give an explanation, which was very concerning. And then telling me that they had a verbal agreement. Well, as everyone knows, a verbal agreement's not worth the paper it's written on. And if there was a verbal agreement or any agreement, it shouldn't have come from the president of the Board of Health. It should have been Ms. Benevento. You can't make those kind of agreements. She's the one that would be the problem, not working on any of the matters. And again, that's disturbing that you hire the wife's firm and we have no record of any disclosure, and it's not coming from the person who potentially did have the conflict. And on top of that, I was advised that Greenberg, the president of the Board of Health, that's one of his former firms. So we're hiring the buddies of the president of the Board of Health, as best as I can see on the surface. And again, with Maven being hired and George Brockler, everyone's saying, oh, there's no problem with that because of the lawsuit he's filed in Arapahoe County trying to eviscerate the power of this Board of Health. But I put your attention to comment 24 of the Rules of Professional Responsibility 1.7. And I would take that under advice and really consider it, and not consider it in the manner of how do we get around it, but what does an objective, reasonable person believe that is telling you? It was always my education that ethics rules were something you didn't run up to the line as close as you think you could. You stayed away from them. The line was there to stay away. So again, I would like to reemphasize to try and paper yourselves and be transparent and do things in the correct manner. And then the final comment I might make real quick is, again, you got the case at the federal court dismissed because you carved out the Douglas County School District. But there are many daycare centers that have 100% compliance with masks that they've imposed, and you still have a arbitrary carve out for anyone that goes into those facilities. I think you may have a problem with those facilities here coming up too and see another suit. So thank you for your time.
Thank you. Is there any other comment?
I have no other online comment.
Okay. Is there any comment from board members? Okay. Well, then I would entertain a motion to adjourn.
Move to adjourn.
Second.
All in favor?
Aye.
Aye.
Aye. Opposed? Thank you all very much.
Yes. Okay, I gotta run to the next job. But good to see you.